Because of some technical issue, I think sir is unable to do it.
Our next topic, next sessional topic is Pediatric Surgical Oncology Global Perspective. Our speakers are Dr. Chan Hung Chui, Mount Elizabeth Medical Center, Singapore, and Dr. Sushmita Bhatnagar. It is customary to introduce our first speaker, who is overseas speaker from Singapore. He is Professor Chan Hung Chui. You can, from the screen, read his qualifications. He is a consultant pediatric surgeon, Mount Elizabeth Hospital, Singapore, which is a famous medical center in Singapore. He has held the positions of Secretary, APSO Executive Council, Head Department of Pediatric Surgery, KK Women and Children Hospital, then Chair Pediatric Surgical Oncology Group of Singapore, and Chair Chapter of Pediatric Surgery College of Surgeons, Singapore, Advisor Children Oncology Committee, Chinese Research Hospital Association, China, and member IPSO, International Society of Pediatric Surgical Oncology. I will invite Dr. Chan. Stage is yours, sir.
Which one? The second one. Okay. Thank you, Mr. Chair. And firstly, I want to thank Professor Sushmita and Professor Pasan Kumar for inviting me to come to Lucknow to join you in this conference. It's my great honor and privilege to do so. So firstly, I think this session I will be sharing together with Dr. Sushmita. What I will speak on is pediatric surgical oncology in the global perspective, and then subsequently she will speak on the perspective in India. Now, so in the practice of pediatric surgical oncology, we all know that we need diagnosis, risk stratification. We need to have good preliminary diagnosis, clinical, radiological. Importantly, for surgeons, we need to also decide whether or not we should biopsy and what kind of biopsy technique we should take and to avoid upstaging, and what are the contraindications for surgery and how to not, because of the biopsy, delay in subsequent adjuvant therapy. And after the biopsy, what we are going to send these specimens for, the pathology, the genomic studies that is now available to help in the diagnosis. And following that, then we need to decide whether these patients would require adjuvant therapy first or surgery. And when we talk about surgery, we talk about the basic principles, techniques, and other guidelines that we need to follow on. And finally, we look at how we can avoid all the side effects of treatment, and if side effects of treatments happen, how we are going to manage it. And all this we actually should come together to discuss it in a multidisciplinary team, and so that we can provide what's best for the patients. I think internationally, what we are trying to do nowadays is many centers or countries actually come together to formulate collaborations, research studies, and these studies help us improve ourselves. What we are doing today, we subsequently look at the results, and then we learn from the results and we improve the treatment subsequently. All right, so that is the so-called the backbone of what the practice of pediatric surgical oncology is. But then again, we know that there will be centers where it is a little deficient. And even in the best centers, okay, this is a paper that I published when I was doing my fellowship at St. Jude in 2000. And this is just looking at pediatric non-rhabdoid soft tissue sarcomas. And there are, even in the United States, with St. Jude as a referral center, we are seeing many patients who have initial unplanned resections. And then subsequently, these unplanned resections presented to St. Jude and underwent what we call pre-treatment re-excisions. And it's found that about half of them, actually, we found tumors within these pre-excisions, pre-treatment re-excisions. And many of them actually, because of the pre-treatment re-excisions, achieved clear margins and subsequently actually did not require further treatments. And so from this, we actually propose that we should do diagnostic incisional biopsies first in these suspicious tumors rather than doing a wide so-called excisional biopsy and not a wide local excision, which is the goal of the treatment. And even years later, this is a paper from COG, whereby they look at the surgical protocol violations in childhood renal tumors. And you can see that about 15% of them actually do have at least one surgical protocol violation, which includes lack of lymph node sampling, of they actually had spillage or biopsy before the nephrectomy, or incorrect abdominal incisions and unnecessary resection of organs. And all these violations resulted in additional exposure of the patients to additional chemotherapy and radiation therapy. And when we look at Asia, it's a very large continent. It consists of high income, middle income, and low income countries. And really, treatment outcome of childhood cancers differs greatly among these countries. And this is a paper done by our pediatric oncologist in Hong Kong, C.K. Lee. And you can see that in many countries, there are treatment collaborative clinical trials happening, but it is actually, even in one particular city, you may have a center that is geared up to do pediatric surgical oncology, but there are many cities that are not prepared to do so. But when the patients present to them, it is still done according to what the surgeon would think is best for the patient. Now, so we take another paper that was published in SIOP PODC, and we actually categorize neuroblastoma treatments according to different settings. And setting 1 is the most basic, and setting 4 is the most complex ones. All right, you can see that at setting 2, there will be CT scans. There's a pediatric surgeon in-house who will be able to perform such surgeries. And then setting 3 is when there's availability of pathological classification, pathological evaluation of these neuroblastoma specimens, and as well as presence of isolation and transplant facilities. And setting 4 is the most complex ones. And so currently, I think we do find that risk stratification is extremely important for us to decide. And why? Because if we do not risk stratify them correctly, we will be giving the patients inaccurate, or we either overtreat them, thinking that they are very high-risk patients, or we actually give them too little treatment such that they relapse. Okay, so I think at this point, risk stratification is extremely important for us to be able to give patients the right treatment. And in Southeast Asia, I think in many countries, smaller countries or cities, they are starting to develop cancer referral centers. And all this usually is not started by a surgeon. It's started by one single pediatric trained oncologist, and then they start off a center, and then they try to get hold of pediatric surgeons to be the oncology surgeons. And over time, they get people interested in pediatric surgical oncology, and we get them to come to our meetings. We get pathologists, we get radiologists who have similar interests. And the initiatives so far established, thanks to the organizations of SIOP, St. Jude Global, WHO, and I think in Singapore and Asia, we have this Viva Foundation for Childhood Cancers. We have national pediatric cancer programs, education and training of the pediatric cancer healthcare workforce. And this allows me to bring you to the conference that is going to happen in 2 weeks' time in Hawaii, and that's our regular conference that IPSO has yearly together with SIOP, and together the radiation oncologists and many other people will be there. And I encourage you to come along and participate in this conference. And so IPSO, this is where I was the secretary of the Executive Council for 6 years prior to this. And this organization is started off by just a simple group of surgeons who with common interests come together in a surgical oncology symposium in Prague in the SIOP meeting. And over the next couple of years, in 1991, then IPSO was formed. And its mission, to put it simply, besides being an educational forum for surgeons, is really to help patients in all parts of the world access state-of-art surgical management by disseminating global best practices in pediatric surgical oncology. Oops. That's right. Wow. Okay, so yeah, so you see, IPSO is a surgical, just like APSO, all right? So IPSO is a society for pediatric surgical oncology. We have meetings yearly together with SIOP. Together, we actually develop surgical practice guidelines is on open access journal eCancer that was published in 2022. I encourage you to look up this one because every time when you are not certain of what to do for a certain patient, you can quickly refer to this. I hope the organization will continue to update this set of surgical practice guidelines. This was actually written by like 84 different surgeons, and it's a 400-page document. All right, so we also try to participate in IPSO and SIOP continental meetings. We also join in the EPSA as well as the WUFAPS meetings as well. And also we represent IPSO, or rather IPSO is being represented in WHO initiatives also. Okay, that's all I have. Maybe invite Dr. Susmita to do the next part.
Well, thank you very much, sir, for your nice presentation. And I think we can go for the next presentation on the same topic, Pediatric Surgical Oncology Global Perspective by Dr. Susmita Bhatnagar. As we all know, Professor Susmita Bhatnagar is a consultant pediatric surgeon, and she is a chairman of our Association of Surgical Oncology chapter, and she is director of Focus Foundation of Children in Universal Support, ex-professor and head pediatric surgery, BJ Badia Hospital for Children, Mumbai, and over 80 articles she has published in various national and international journals. And she is keen interest in pediatric hepatobiliary surgery, pediatric oncosurgery, and pediatric incontinence management. So with this brief biodata, I invite Madam, kindly go ahead. Thank you.
Thank you very much, dear chairpersons, for the lucid introduction. And the Indian perspective that I'm going to be talking about today is everybody is aware of it. It's just that some data I have compiled, and this is not a topic which can be actually taken care of by just one person. Today, all of us here are together. We have had one special session we have kept only to identify the challenges. Whatever is good, we don't really need to, we can only improve on that. But whatever is missing, whatever is a gap, we need to really brainstorm, come out with solutions and implement them, because implementation is the key to everything. If we just discuss and then we go home and go back and do the same thing, it really won't make any difference in this world. And we want to make a change. We want to make a difference in this world. So let me just touch upon what all, this maybe I could discuss at some other time. Very briefly, I could just say that we started off as a surgical oncology section of Indian Association of Pediatric Surgeons, specialty section in 2006. And in 2018, the section was registered with the charity commissioner. The constitution and bylaws were formed, a new PAN card, new bank account, all of it was done. And we had the first annual conference, first annual dedicated conference of surgical oncology section, that is the SOSCON. It was held in Goa in 2018. Followed by that, we are having routinely conferences. And in 2024, we are here today with a membership strength which is more than 300. And we have had significant strides which we have made. But yes, we need to identify the gaps, the challenges, and how to move forward. So there has been a publication in 2023 itself, very recent, where an assessment of the childhood cancer care services in India has been done. There have been like so many authors to this publication. So these are excerpts from the publication. So they mentioned that in 1960s, the first pediatric oncology unit was started, and later on it increased from 1980 onwards. And a national survey of these services was conducted in 1988, and it was observed that around 50% of the cases were handled by the pediatric oncologists. And has the situation changed today? Not much, to be honest, but we really don't have an exact data, because such surveys and such studies are very difficult to conduct, first of all. And secondly, the participation is scanty as well as scattered. It's not uniform across the country. So they have conducted a survey with the inclusion of 137 tertiary level and 92 secondary level hospitals in 26 states and 4 union territories. Public and private care hospitals were all included. So they have done descriptive statistics, which was used to primarily present the health service status and data. They found that a dedicated pediatric oncology department was available in only 41.6% of the public hospitals, only 48.6% of private hospitals, and 64% NGO managed tertiary level hospitals. And in 39% of the 92 hospitals providing secondary care, childhood cancer care was provided. There are a lot of other data that we have, like availability of diagnostic facilities, like bone scan was available in 41.5%, PET scans were available in 25.9%, and this figure was lower in public tertiary hospitals. Histopathology, CT scan, MRI were lower in public secondary hospitals than in private and NGO managed hospitals for the corresponding level of care. And most of the tertiary hospitals had the required supportive care facilities, except for play therapy and hospice care. So generally, most of the Indian setups do not have that. Some of them do have it, even in public setups. Less than 50% of the public tertiary hospital had stocks of the 4 categories of cancer treating drugs and essential infrastructure of radiotherapy and chemotherapy. And most of these secondary level hospitals not treating the childhood cancer had referral linkages with tertiary hospitals. Following the analysis, it showed that the concentration of availability of childhood cancer care services were at the tertiary level of healthcare. There were gaps in the availability of specialized pediatric oncology care in all tertiary hospitals. The availability of childhood cancer care services were higher in private and NGO managed hospitals than in the public hospitals. Integration of this as a national cancer control response should be taken up as a matter of priority. And to formulate childhood cancer policies that will enable timely access to care universally. So they also have published some data according to the National Cancer Registry Program and the report in India, and also the Ministry of Health and Family Welfare National Program for Prevention and Control of Non-Communicable Diseases. The entire article, you can always read it up. I can provide you the link or put it up in the APSOCON group. So realizing that there are issues that we need to deal with so that we improve our Indian status and the outcomes. We have also a publication earlier by Dr. Ramandeep Arora, I guess. I don't remember which year, but he has published that the outcome of 5-year survival, tumor-free survival is just about 50 to 60%. In India versus countries abroad where it is 80% and above. So looking just at this figure, we know that we need to do something more than what we are doing so that things can be better. So our APSO team and our executive committee members from the 5 zones of the country of India, Dr. Manoj Joshi from the central zone, Dr. Prabodh Goyal, Dr. Monica Bhagat, West Zone, Dr. Prabodh from the North Zone, Dr. Senthil Nathan from the South Zone, and Dr. Santosh Mahalik from the East Zone. All of these 5 executive committee members have collated some data from centers who agreed to be part of this survey. So somewhere around 30 hospitals have participated overall. And we have found, I have compiled the outcome of all the problems that they have faced. So the first thing which really struck us, which we know already, was that there have been delayed presentation, and even after presentation, there has been a delay in diagnosis. So by the time actually the patient comes for treatment, he is already in advanced stage. And once this entire diagnosis is made, then comes the question of, okay, how long will be the treatment? What will be the finances? Whether the patient will be able to afford. Affordability here becomes a major challenge, especially when it is a girl child. And this has been noted all across the country, individual institutes as well. I'm sure all of y'all will come up with so many stories like these. And then once the treatment, if we overcome all these challenges and we treat the patient, then there is a poor follow-up. So this is one thing which we really, really need to tackle. So once we actually, we will have to formulate strategies to do this as well, because it's not at the level of the pediatric surgeons only. There are multiple areas which we will need to touch upon. The another major deficiency is lack of specialty pediatric services. I mean to say the pediatric oncologists are lacking in many institutes, wherein the pediatric surgeons themselves are giving chemotherapy, or maybe the radiotherapist is giving chemotherapy. Something like this is happening, or maybe the adult oncologist is giving chemotherapy to the pediatric patients, meaning some interim solutions are being done. Pediatric oncopathologists are not there enough. Pediatric radiodiagnosis or radiologists, oncoradiologists are not enough in all centers. Pediatric radiation oncologists, that is another very major part where there is deficiency in almost all centers across India. Few centers do have, but only few centers have. Then it was also found that we have deficiency of multidisciplinary care team within the hospital, which means that if the patient goes to a surgeon, the surgeon treats the patient. Without having a multidisciplinary approach, as I mentioned earlier, we need to have an ecosystem. A patient with a malignant tumor is a part of the ecosystem. A pediatric is the main center actually of the ecosystem. Pediatric surgeon is one part of the ecosystem. He is not the whole and soul to manage the patients. Pediatric oncologist plays its own role. So there are several parts, 7 to 8 parts of this ecosystem, and all of it need to be in place. How many institutes in India have this? Not many, right? So this is also we need to work on. Then there have been some recommendations from this survey that we should have a nationwide funding system. I'm not sure whether how much we can do on this aspect, but as APSO, maybe we can brainstorm and look at what options do we create for patients all over the country who are poor. There are poor patients who have facilities in government hospitals, which is totally free of cost. But not everybody can avail of those facilities, and not everybody has an access to those. So maybe we can look at this as well for improving the care of children with solid tumors. And then most important, we really do not know what is happening where. So we need to have a national tumor registry. We also need to have the surgical guidelines, as Professor Chan mentioned, and we need to have our data in place. So somebody has to do this. Now, who will do this is what we have to come at a conclusion by the end of this day. But this is what I found. I'm sure I've missed out quite a few other issues which are probably as significant, which we come across on a daily basis. But I found these to be the main things which will really impact on the final outcome of children with cancer. Thank you so much.
Thanks, Sushmita, for the nice lecture.
Thank you, madam. And thank you, Professor Chan, for broadening our perspective in the current trends world over. And I'd also like to thank you, chairpersons. Before we move on to the next session, I would request Professor Dr. S.K. Biswas, sir, to present a token of gratitude to Professor Chan. Yeah.
Stop sharing that slide.
Yeah.
Just switch off the.
Yes, thank you. Just let's switch it off, please.
Clapping once more. Oh, no, but we don't know now. Because then the faces come down.
भैया settle down कर दो.
And I request Professor Chan to hand over a token of appreciation to Professor Sushmita Bhatnagar. Now I request Professor Chan to give a token of appreciation to Dr. S.K. Biswas, sir. Go. I request Basant sir to give a token of appreciation to J.D. Roberts.
Yeah, sorry for this little mismanagement, but just we are learning, so please excuse us. And I'm also sorry, this was a very nice topic and session was just finished abruptly. I request you all, if you have any discussion or any comment over this topic, please go ahead. We have 5 minutes. My seniors, Sandeep sir, you want to say? You have mic on your table, just on it and speak. Karim sir, you want to say some? Sandeep sir, yes sir.
No, sir. What is? My only one question is, what is the status of National Tumor Registry at present? We are talking about the National Tumor Registry to be made from since 1980. What is the present scenario of Indian National Tumor Registry in pediatric oncology?
It's very difficult to answer me. I think Susmita ma'am can answer.
So as within the APSO, we have been discussing this for almost a year now. We have prepared some documentations, but we were not able to complete it. So hence we have not announced it this time, but we will be talking about it in the GBM. We'll be taking inputs from all of y'all, and we will prepare this whole thing in 1 year's time, 1 month's time. So we will start something of our own so that we, at least the surgical part, meaning we may not have the rest of things. The pediatricians have some groups, the INPOG and all these things. So maybe we can collaborate with them, but then they don't include so much of surgical part. Right? So we need to do that because that is a huge lacuna.
The Indian Tumor Registry and produces some annual reports, but they are most incomplete. And I think the most sincere efforts have been done by Ramandeep Arora, who is a pediatric oncologist, epidemiologist. He was in UK for many, many years. And then about 10 years back, he came to India. So he's done most of the papers on epidemiology in pediatric oncology. He'll be the lead author. So they're doing good job. INPOG has done a lot of good job. I think that's a good idea that APSO should work with the INPOG. In fact, most of us should become their members as well. So that will bring in some data eventually.
Now I'll request the chairpersons for the next session. Professor J.K. Mahajan sir, Professor and HOD, PGI Chandigarh, and Dr. Manoj Kumar Mohanty sir, Professor and HOD, AIMS Bhubaneswar, to join us and to kindly introduce the speaker.
On behalf of organizers, I welcome you all to this next session. And next speaker is Professor Jan Godzinski. It's my privilege to introduce him. He is chair of surgical subcommittee on SIOP RTSG group. He is also participating in Harmonica project. He is author of more than 208 articles and chapters published in Polish and other languages. He is a lecturer at UPSA International Course on Pediatric Surgical Oncology. So Professor Jan Godzinski, welcome.
That's okay. It's okay. Good morning, everybody. In Polish, we are saying dzień dobry. First of all, warmest morning regards to all the participants. The room is full with people, which makes always great pleasure to presenters. Where I'm from Poland. This is a country in the European Union, far away, more or less 6,000 kilometers by air. Thanks a lot for inviting me for APSA conference this year, and welcome to Wrocław at the soonest occasion. Some of you visit my place, like Professor Sandeep Agarwala and Sajid Qureshi as well, at the occasion of oncological meetings. So I think that once we organize the next one, I'll be delighted if more Indian friends could come. Our today's topic is exploring the role and implications of nephron sparing surgery in unilateral venous tumor. Why this topic? It is still controversial. Some points against, some points for. Against, very well known, humans have two kidneys. Why to take a risk? Why to take a risk of oncological failure trying to spare part of one? And even for stage one, if after classical surgery the survival is close to 100%, why to risk a 30 to 40% decrease in case of R1? And some answers on that questions. It is false. Some have only one kidney, some will have metachronous bilateral disease. This is true for 3% of patients. Some have venous tumor predisposing syndrome and renal failures related to the syndrome, like Beckwith-Vidian, mainly Dennis-Drash. We still discuss whether in Dennis-Drash it is better to do complete nephrectomy because those children wait for transplant anyway, or spare kidney and do the transplant later on. Also, some, like kids, will have accidents and may lose the remaining kidney. Unfortunately, there are very few reports on the late functional results, but take into account that we are basing upon adult data where the life expectancy after cure from renal cancer is 15 to 20 years, because the peak of incidence is at 60 years. In our patients, this life expectancy after cure is 70 years. So remaining kidney have much more time to get vanished. And even if we ignore all the above and look at the relapse risk only, if patients are correctly selected for NSS, they achieve the same 100% overall survival with radiation therapy used in very few of them. What is a practical impact on patients? Practical impact of chemotherapy. Chemotherapy is very important for nephron sparing surgery, which is practically impossible without. A very nice paper by UK colleagues based on a UKW3 study, randomly tested the results in immediate nephrectomy group, in the late nephrectomy group. And you see that stage one
after immediate nephrectomy is in half cases, stage 3, in 1/3 of cases. In delayed nephrectomy, stage 1 is 65% and stage 3 less than 10%. Overall survival and event-free survival are the same. But stage 3, what does it mean, stage 3? Stage 3 means that we will have to irradiate the patient and probably give him also anthracycline in some cases. What is the prognosis in those cases? After upfront nephrectomy, we have more complications, ruptures, less stages 1. We have radiotherapy more in use. We have nephron sparing surgery in unilaterals, practically impossible. In delayed nephrectomy group, we have less complications, less ruptures, more stages 1. Very little of them need radiation therapy, and nephron sparing surgery is possible, as we estimate in big volume centers, even in 10 to 15% of cases where we are sure to achieve R0 resection. That makes a difference because we have the same outcomes, but we give much less treatment. That's true that in this group, we still have certain risk of misdiagnosis because we are putting this diagnosis on the basis of imaging only, sometimes through cat biopsy. Few words on history. I'm quite old now. That's why I would like to speak about history a little bit. Let's start with those who were surgeons and who opened the door to successful treatment of renal tumors, so-called Boston School of Pediatric Surgery, and 2 gentlemen, Dr. Ladd and Dr. Gross. First, we were friends and cooperated, then became rather enemies. But anyway, they were first who reported documented reports on cure, and then documented curve of survival at the level of 10% at the times. And they were unhappy with this. They started to think how to change surgical technique, and they introduced something we are doing up to now. Wide transabdominal approach, transverse, and early ligation of renal vessels, and immediately the survival rate raised to 32% in localized tumors. But imagine what diagnostic tools they had at the time to discover metastasis. Just chest X-ray and opinion of a surgeon after opening of the abdomen. So probably in this group, there are some patients with small mets not seen on chest X-ray as well. And the real rate should be probably higher. Next 10 years brought important achievements and more tools for the treatment of renal tumors. Cytostatics are coming, and look at the Farber and Burgert composition. This is nearly what we are doing up to now. Radiotherapy, surgery, and actinomycin D plus vincristine. 35% of 3-year survival in stages 4 in 1956. It was something incredible, something with a great achievement, a milestone. What were the next steps? Organization of big international or multi-center studies. The American colleagues were the first. They organized first called NWTS, then up to now CUG, a group which gathered American centers who treat patients according to common protocol. And 2 years later, SIOP. I'm a SIOP man since 1989, and that's why I will focus on SIOP did for renal tumors. First, our question were how to change the situation on a very high rate of tumor ruptures. And the question was whether radiation therapy will help or not. And the answer, as you see, was affirmative. The rate fall down to 4% of cases and 31% of stages 1 were generated. It was already known that radiation therapy is nothing very good for kids. And next question was whether this has become a golden standard up to now. This is a classical situation, a big lump in the left kidney after 4 weeks of simple chemotherapy. You have very nice regression. Of course, this is not a candidate to NSS. How do we treat a patient preoperatively? Very shortly, as you see on this slide. How do we treat them after surgery? That depends on stage, group of risk, and also volume of the tumor. In intermediate risk patients, volume over 500 milliliters has negative impact. In red, you have cases in which radiation therapy is to be considered in a treatment, and also anthracyclines. So these treatments put in red are potentially harmful to children. Prognosis is also different for different pathology subtypes. For low and intermediate risk, we have very nice overall survival and very nice event-free survival. However, the treatment for intermediate risk patient is markedly more aggressive. With the high risk, we still have problems, and nearly 30% of cases are lost. We still have to work to improve that situation. Non-responders. There are two groups of non-responders. This is very important in planning further treatment. One group are only a little aggressive tumors like CPDN or stromal predominant. They can be quite a big lumps, but they are not infiltrating surrounding structures, and even big tumor, stromal predominant, may be submitted to nephron sparing. Now at MRI, we can quite clearly distinguish that subtype from other types. The problem is with diffuse aneplasia, which is highly malignant and infiltrative, and it is also important that if it is not completely resected, child has a great chance to get relapse, and treatment of relapses of diffuse anaplastic tumors is very, very difficult. Where we are, we have nice overall results, but still major problems with some subtypes and some histologies. But we use the same drugs in 70s. We have the same policy. We have practically the same overall survival since SIOP-9. And we do not have any close perspective to get new drugs, which would be much more effective. There are a lot of research, but still not a revolutionary drug. But we improved. Anesthesiology improved, surgery improved technically, and imaging improved technically. So we can refine surgical strategy, and we can perform nephron sparing surgery much more than before. We can also more successfully treat bilateral cases, relapses, IVC, thrombus, and this will be today's topic. And for those who still don't believe in NSS, just a question. Who in the room would do total nephrectomy in such a case? But such situation is unlikely without pretreatment. Not only ideas, but also research were done on the basis of SIOP material. This is the paper by Jim Wilde and myself and other colleagues. We analyzed 97 carefully selected cases of more than 2,500 patients registered in SIOP 2001. It is 3.8%, and those patients were submitted to nephron sparing surgery and were unilaterals. And look at this, after nephron sparing surgery, we have 100% survival and more than 95% event-free survival, and it is better than after total nephrectomy. Why better? Of course, patients were selected, and selected very, very carefully. But failures are more interesting. Failure in nephron sparing is when we have a stage 3. Stage 3 may be the result of positive lymph nodes and positive margins or SPIL. If SPIL and positive margins are more or less surgeon dependent, the question is how to predict the status of lymph nodes prior to surgery. We checked how the basic imaging behaves during chemotherapy prior to surgery, and surprisingly, not a change in volume of the tumor, but initial volume has an importance. If a tumor is less than 300 milliliters, patient has twice smaller chance than a normal group to have positive nodes. That means if the whole group, we have 5.5% of positive lymph nodes in small tumors, only less than 3%. And this is not a lot. I think that this is worth risking. And this is the shortest guide how to perform nephron sparing surgery, which cases should be selected. Of course, peripheral tumors, of course, polar tumors, not conflicting vessels, not conflicting collective system, and not healer ones. Yes, we go through Zoom. Yes, I think I need help. Yeah.
Yes.
No internet.
Yes.